bring everybody up to date on what's been happening at the legislature, what might be happening, and try to give us an idea of what some of the hot issues are going to be. The council, we are a small state agency that's this year we'll be celebrating our 40th year of existence. We exist purely as an advisory agency to the governor, state legislature, state agencies, and the public regarding disability issues. And one of the things that we do are events like this. So we're pleased to be here today to be able to bring this event to you. We've got several legislators that will be with us here. We'll be talking about the state of disability issues, because that's key and important to us. Key disability organizations will be here to talk about what their legislative platform will be. And also you, the community, will get a chance to ask questions throughout this time this morning. So again, we welcome you. Let's see here. We've got folks that are at a couple of different locations. Make sure your microphone is off and on mute, and we'll let you know when we come to the question and answer period. We've got folks, I'm sure, via web sitting at home or in their office, and you can be emailing your questions to council.disability@state.mn.us, and I'll try to remember to say that throughout the time. So you can send email questions as well. So I think we're going to get started right off and welcome up our in-house attorney we love, Ann Henry from the Disability Law Center. She keeps us on the straight and narrow and really brings us all the good facts and figures that we need to know about what's truly happening in our disability community. So welcome, Ann.
Thank you. Thank you very much. And welcome everybody out there that we can't see in cyberspace. And everyone here, of course, in St. Paul. I do have a handout, and we think a PowerPoint. It's, of course, too much information for 15 minutes, but that's fine. You can take what you need out of it. I did start out with 2 slides of acronyms just to be sure that everybody is caught up on some of the acronyms you're going to hear a lot about, and you'll see in the PowerPoint, given the space limitations. I just want to point out the Affordable Care Organization, ACO. You will hear that a lot. It's related to health reform. We don't have time now to go into it, but I'm sure as the session goes on, we will have an opportunity to dig deeper into health reform issues. And so I leave you with those for hopefully your reference in the future. The first substantive slide is really about the budget forecast. And when looking at the state of the state and disability services, we really have to look at the budget. A lot of people with disabilities rely upon services publicly funded through the Department of Human Services and the Department of Education and DEED as well. And so the state of the budget is really crucial and ends up driving what we work on. The good news, and you'll hear this, and it's important to recognize what we're talking about. First, we heard there's a surplus in the current biennium. That's very good news. This is apparently the 3rd surplus for the current biennium. Now, the good news needs to be tempered by the fact that the current biennium is less than 6 months to go. It's over June 30th of this year. And then we go back to a large deficit. And that is really what we're facing for the coming session. The deficit is $1.1 billion, and I think starting in 2003, inflation wasn't officially counted, although gratefully the Department of Management and Budget always tells us what the inflation would be so we can see the real figure. Not being straightforward about it doesn't make the cost go away. And so we really have to look at, I think, about a $2 billion hole that we're looking to fill. This is, of course, discouraging and alarming. It has been this way for most of the last 10 years. We have had deficit after deficit, and I have come and talked to you again and again about the last session and the cuts that people have endured across disability services. And unfortunately, we're facing that again for the coming biennium. The next biennium begins July 1st of 2013. And so that's really what we're going to be dealing with at the legislature. The surplus for the current biennium, the $1.3 billion, was used to repay part of what we owe the schools, and we still owe $1.1 billion. So that's another piece of what we're facing on the fiscal front that must be kept in mind. A key date that will really focus all of our attention on what we're down to is the February forecast. That's what the legislature uses to set the budget for the coming biennium. Another date, not on the slide, is the governor's budget release date of January 22nd. This will also be very important. Put it on your schedules. It's going to be very important to find out what the administration's proposing in terms of spending cuts, changes, and new revenue for the coming biennium, and it'll give us an idea of what we're facing on disability services. So before going into sort of more of an overview of specific issues, I just want to review some of the changes from last session and remind us all that we're still feeling the effects of the worst recession in our history. We still have a lot of people unemployed, and we still have, as I just reviewed, a lot of problems with our budget situation and the debts that we have to repair, really. We had a very contentious session, as you'll remember, in 2011, resulting in the state shutdown and a special session. The 2012 session last year did produce some modest changes and didn't have those huge explosions of special session and shutdown. One of the factors involved was that the managed care organizations had $35 million that relieved the budget in Health and Human Services, and I think allowed some of the changes that were very important. One of them, it was the change to medical assistance for employed persons with disabilities. People can keep working after 65 and benefit from their earnings. That has been terrific. Also, gratefully, the 20% relative PCA cut was delayed, but let me emphasize, delayed. That issue has got to be dealt with, and it should be a key issue for many of us. Also, the 1.67 provider rate cut was delayed. These are providers that provide all of our community support services, and that was delayed as well, but we will face that again this year. So what's the state of the state? Really, the best word I have to describe it is everything is in motion. Everything that people with disabilities rely on. We are undergoing, and you can pick your term, change, reform, streamlining, renovation, etc. And it's really, I think, driven by a number of factors. Certainly the push for change by persons who use the services. People know things could be better. They could be done in more efficient ways with more self-direction. And so that's definitely a factor in why everything is changing. Also, and I think probably primary, are the harsh cuts that have occurred over the last decade and all of the deficits. We have continued budget pressure, state level and at the national level, a lot of unknowns at the federal level. And we definitely have the need for long-term sustainability. The amount of change and rolling over and changing everything that people have had to endure really, really has been tough. I think people feel quite at sea, and it's difficult to make plans for your life as every year new changes or cuts have been happening. So to turn now to the gaps that remain, that I think are really right in front of us. Again, the 20% relative PCA rate cut, we've got to repeal that thing once and for all, and hopefully that will be included in the governor's budget. The disability home and community waiver caseloads have been limited starting back to 2002. We have had some growth, yes, but not keeping up with need at all. Now, this year, included in the forecast, and I want to point this out because I think we all have to keep our eyes on this, included in the forecast because of previous legislation, the waiver for persons with developmental disabilities will rise from 6 a month to 15 a month. Now, this is in the face of a waiting list of 3,600 people, so it's a very modest increase. But when we are talking about a $1.1 billion and with inflation $2 billion deficit, I worry about increases in the forecast and what will happen when push comes to shove. So keep your eyes on this and be sure to support it if this is something that is important to you. Also, the waiver for persons with that are otherwise eligible for nursing facility care, the CADI waiver, rises from $60 a month to $85 a month. That program also has a waiting list of 1,200 people. And again, it's a forecast increase, and we need to be sure that that is maintained. And actually, I think we ought to be advocating to increase it. But that's, of course, very, very tough in a deficit year. The 1.67 community service provider rate cut, again, effective in July, I think has to be dealt with as well. We also have quite a roiling mess going on, I think, in terms of corporate adult foster moratorium, our licensed bed closure, voluntary closure provisions for the home and community waiver programs. And these are the 4-bed adult foster corporate homes. We really need better information. There's legislation to do a gaps analysis across the state, but we don't have that information yet. And we know that there's just a desperate need in some areas of the state for residential services. So what's ahead? Well, we know the nursing facility level of care is going to become more stringent in January of 2014. And these changes affect people on the CADI waiver and the EW waiver in particular. It also, of course, affects a lot of people that either are or will be eligible for nursing facility services. We have a brand new assessment that's going to be used for community services across the state, across all ages, across all disabilities. And this has been under testing and use in a number of places in the state now, and it is supposed to roll out across the state this year, 2013. So be ready for change and be alert to learn about it so that you can share this information with other people. We are also expecting that the Medical Assistance Reform 2020 waiver will have some action by the federal agency. The waiver was submitted in November. The deadline for comments to the federal agency is actually today. One of the big aspects of this is that personal care assistance services are going to be changed into what will be called Community First Services and Supports, CFSS. And the Department of Human Services is using federal authority under the Affordable Care Act to really reform this program and make some really, I think, some very good changes in terms of allowing better self-direction, allowing the PCA service itself to teach people skills for skill acquisition and skill development. There's a broader definition of instrumental activities of daily living, the things you have to do to keep your life going in the community, a direct reference to community participation, so the services can be used to assist people with community participation. So there are many, I think, positive aspects about it. We do, though, have a very serious concern, and that is that so far the Department of Human Services has not proposed to repair all of the damage done by changing who can get the services. These changes were made in 2009. You'll remember that was a big year of cuts in PCA services. And we still have language that limits the availability of these services for people, especially those who have a mental health condition, an intellectual or developmental disability but no physical disability, and people, again, without physical disabilities who have brain injuries. We find that those people have a harder time accessing it because of this definitional problem. We've commented about that to the feds, and we will continue to work with the department on it. Also, part of that reform is an intensive care coordination for children, some health reform issues, again, with accountable care organizations and some care coordination, especially for people with more complex conditions. There's an employer navigator proposal there, and housing stability and transition from homelessness, as well as some proposals for Anoka Regional Treatment Center. And we expect that we'll see some legislation on these issues during the session. We know the Olmsted Plan is due in June, and we're going to hear about that a bit later from Chris Bell. And also, I really think it's time to remind everybody that in 2011, as part of some significant cuts, the out-of-pocket costs for people who use medical assistance for employed persons with disabilities was raised substantially. This was sort of a quiet cut, given we had a lot of things going on, and it was not to be effective until 2014. That was because the Federal Affordable Care Act did not allow the changes to be made until 2014, when some of the requirements under the Affordable Care Act come into play. But people are going to have premiums of $65 minimum, and their out-of-pocket, their unearned income contribution is going up times 10. It's going from 0.5% to 5%. So please join with me in assuring that everybody out there who uses this program, I think we're now about 8,000 people, knows this is coming, does the math, and figures out how to adjust their budgets, because we don't want a lot of crises happening next year that are going to mean people can't pay the rent, or they can't get to their jobs because they don't have enough money given these huge out-of-pocket cost increases. It's very troubling that we're doing this at a time when we're supposedly working on affordability of health care for everyone. We really are going the wrong direction with this cut. Also on the list for the coming session, expanding medical assistance under the Affordable Care Act to 138% of the poverty level. This has so many opportunities for people with disabilities, especially younger people who have not yet gone through the whole disability Social Security process. They are graduating from school. They perhaps are ready for work, and they could work and still qualify for medical assistance without having to declare that total and permanent disability. And I really can't emphasize enough how discouraging it is for so many young adults and their families who've worked so hard in school and put themselves on track for work to have to go to Social Security and declare that they're totally and permanently disabled and can't work anywhere in the national economy in order to get health care. And that has been the reality for way too many people over our history. So I think the expansion of Medicaid offers that opportunity. One of the key issues is whether we're going to have a good benefit set. If our benefit set remains robust, then this is terrific. And so let's be sure to tend to that issue. I've already mentioned the personal care changes. We have home and community provider licensing standards, and embedded in there are some limits on aversive practices, which I think are very important. We see too many people having their basic rights limited as punishment or consequence for things like not cleaning their room. We're talking about adults. Now, if we did a survey here, how many of you made your bed today? Not everyone's hand is up, I notice. Okay. So it's things like this that really have to change, and these are, and there are also uses of restraint. We know that these practices don't help people learn and become more independent. We know that they waste money and waste people's time. So hopefully we will have success in improving that. There's also waiver rate payment methodology. We know anytime money's involved, it's going to be controversial. Let me tick through the rest of these quickly because the time is running out here. Mental health service improvements. We've got issues with ARMS services, adult mental health rehab services. I know there is work underway on intensive mental health rehabilitation services and many other issues. Non-emergency medical transportation recommendations are going to come forward this session. Lots of issues on autism for children and for adults. Private coverage, Medicaid coverage, residential services, education. Lots of issues. The Quality Council. What's going to happen to the Quality Council? What's the funding? This is at the Department of Human Services and really is to govern all of our home and community services. Then we have health reform, not a simple, easy issue. Lots of things. Benefit set, already mentioned. Definition of medical necessity could come up. And again, expansion of adults for medical assistance. And then we have the Department of Health putting out a lot of legislation on home care regulations. We have education, special education funding. Reform is being talked about quite broadly. We have state special education provisions and the issues of aversive practices there and prone restraint. And then finally, need I say jobs, employment for persons with disabilities desperately, desperately needs attention. So, as always, you are all needed at the Capitol. You're needed at hearings, at Tuesdays at the Capitol, in your representatives and senators' offices, in the rallies, in the galleries, and with your organizations. So please do make time for that. But you're also really needed in your local district. We have a substantial number of new members who really need to meet their constituents and understand their issues. So make sure your senator and representative knows who you are. And thank you very much. You folks are the key.
Well, Ann, thanks. That was a lot. A lot in 15 minutes. And, of course, a concern when you use the expression, everything is in motion, immediately what comes to my mind is motion sickness. So we're going to have to do a lot, like you said, to be active at the Capitol and meet with our legislators and really let them know what's important to us. So thanks, Ann, for all your work in the community. Definitely, we couldn't be doing this without you. So thanks. Right now, we're assembling some of our legislators that are going to be speaking with us here this morning. So I think we're going to start with the first one who's here gets to speak first. So welcome, Representative Tina Liebling. Let me just do a little introduction. Representative Liebling is from District 26A in Rochester. Actually, that's home to our board chair, David Schwarzkopf, who I believe is online. I don't think he's at the Rochester location, but just at home online. And as Representative Liebling, she is the chair of the Healthcare and Human Services Policy Committee. So I think you're going to be talking about some of the expectations for 2013. And so welcome. Feel free to we've got plenty of time here, so you feel free to, don't take a half hour, but you can take 5-10 minutes.
Yeah, well, thank you. Thank you for inviting me, and thank you all for attending, and to the people who are online this morning. And I feel a little lonely here at the table because 3 of my colleagues are supposed to be joining me. I don't know. We haven't talked to each other this morning, but the other people who are the other legislators are the chairs of the other Health and Human Service committees. So
they're on their way.
I hope they are, because this is a big enough task to do in a group of 4. So certainly, I don't think I can carry the ball for all of us, but I wanted to start, first of all, by thanking Ann for her good summary of what is before us. And I have to say that I think the disability community is very well represented at the Capitol, not only by Ann, but by many different groups, including the State Council on Disabilities. So when we listen to Ann's overview, we can understand how complicated all of this is. And I know all of you could just take the test and pass it like that now, but I certainly couldn't. And I've been on the Health and Human Service Committees for 6 years now, and I have to say I think this will be the heaviest lift this year that we've had in many years because of the Affordable Care Act and our requirement that we implement the healthcare exchange, health insurance exchange, I should say, on a pretty tight deadline. And that in itself is a very complicated, heavy lift for all of us. And remember that legislators are not experts, and it's often said that our knowledge is an inch deep and a mile wide, and I think that's true. So Ann's challenge and the challenge of all of you is to get our knowledge to be just a little deeper than an inch. And I'm glad that this is a true team effort, and that is really how I look at this enterprise, because the governor, I think, has a sign in his office that says, "None of us is as smart as all of us." And I've adopted that as my motto as well. And I asked him about it. He said that came from Governor Perpich. So I don't know where Governor Perpich got it, but it's certainly true. And I think my fellow committee chairs really look at this as a team effort, because the issues before us are so weighty and so complicated that there's just no other way to approach it. We need all the minds brought to bear, and we're going to need all of your help and the help of the entire disability community just on the disability pieces. So Ann's given you somewhat of an overview of some of the things that are before us, focusing on the disability issues, but the issues are very, very broad, and of course they're intertwined. And I'm glad I'm not chairing the funding committee, but the policy committee actually probably has an even heavier lift this year because of the broad range of issues. So one thing I would like to add to Ann's discussion of the budget and the pending deficit is that it really doesn't, it accounts, the way the budgets are done, it's obviously an estimate of what is expected to come in, what revenue comes in, and then what our expected expenses are. What it doesn't account for, as Ann said, is inflation, but it also doesn't account for just plain old unmet need that just has been taken off the table, that wasn't budgeted for in prior years. And what begins to happen, and I saw this before when the DFL took over the majority the last time I was in this situation in the House, where we went from minority to majority, all of a sudden we start to hear about needs that people didn't want to tell our predecessors, perhaps, or they told them and that weren't accounted for. But the needs are very real. And but the simple fact is, everybody knows we can't meet every need. We just can't. We never will be able to. Hopefully what we will be able to do is kind of triage things and make sure that we keep that the things that are most important and that really have the most impact we are able to fund and to continue along doing. Because we all know that part of what makes Minnesota a great state and part of what makes our economy a strong economy relative to the rest of the country, a lot of that is what we do in health and human services. And as the ACA was rolled out and is being rolled out, we see again how much Minnesota is ahead of the curve in a lot of the things that we do. That in no way means that we can't do better and that we won't work hard to do better. But I think it says that what we do as a community and the way we see each other as being interlinked, the idea that we all do better when we all do better is a real Minnesota value, and one that has actually played out in our economy, and the fact that people do want to move to Minnesota, they want to live here, they want to work here. I've heard from so many people, even in my own community, they took the job in Minnesota because their disabled child was going to get better services here than somewhere else. So even in that way, I think it's very important when we try to attract talent to Minnesota and people who have disabilities who may have wonderful job skills that we want to attract them as well. Everybody having good services for folks with disabilities and integrating them into the community and giving them the best opportunities is part of what we need to do as Minnesotans for our economy and for our quality of life here. So we know that this piece about having people with disabilities be more in the workforce is a very important piece. And as we look ahead, even though now it's been difficult to get jobs and so on, we know that we're going to be facing workforce shortages in the future. And my attitude is that we need everybody to use and to develop their skills and to be part of the workforce. Not because we're nice people and it's a charity thing, but because we can't afford to do otherwise. We need everybody to participate in the economy. And the flip side of that as well for people with disabilities is that we need a good, strong workforce of people who provide services for people who do need more assistance. So that's a very important piece of this as well. And finally, part of our focus, of course, because we always have limited dollars, is the efficiency of what we provide, trying to use our dollars the best possible way we can. And it's very important to me, and I know to many of my colleagues, that every dollar, every public dollar that is set aside for use for providing health care and human services, that I want to make sure that that dollar actually buys health care and human services to the greatest extent possible, not overhead, not profit, not waste. And how we do that that's a big challenge for us. But as we move ahead, we know that health and human services is a large and growing budget. Sometimes we hear people say, oh, waste, fraud, and abuse, and the reality is there's always going to be waste, fraud, and abuse. It's a constant struggle to make sure that there is not. The main reason the health and human service budget grows is because the need grows, and the things that we are able to do grows. So if we have treatments that are expensive but that work, that adds to our budget. It's not waste, fraud, or abuse. But at the same time, I want to make sure, to the extent that I can, that our budget is actually going to provide services for people who need them and to improve the health and the well-being of all Minnesotans and ultimately to improve the lives of Minnesotans. And if we can do that, I think that we will have succeeded. So thank you very much. Thank you. Senator Sheran's here.
Thanks, Representative Liebling. We will, since we're gradually getting more legislators here, this is great. I think we'll move on to Senator Kathy Sheran. And Senator Sheran, you're from District 19 in the Mankato area, and you are the chair of the Health and Human Services and Housing Committee. So welcome. We're asking legislators to kind of give us your ideas of what maybe shaping up for this session and what to expect and how we can be there to help you and to help get our efforts across as well.
Okay, thanks, Joan. I wish I had heard everything you'd said.
You could just say ditto.
What is the name of your committee going to be? We're just getting to have conversations ourselves, you know. So I'm interested to hear what Representative Liebling said.
Actually, the thing I forgot to say is that I'm really looking forward to the four chairs having a very close and good working relationship, and I think people will see that to a much greater extent, we hope, than we've seen in the past, especially between the House and the Senate. And it's because we have so much on our plates this year, and Senator Sheran's committee is the corollary to mine, even though I don't have housing in my bucket. So you've got an even heavier lift than I do, but the idea that we would coordinate, that we would try to be on the same page as much as possible, because we simply have too much work to do otherwise. We don't have the luxury of having any little squabbles or losing our, not having an efficient, smooth system. So I think that people will see a much smoother and more coordinated effort, and of course with the governor and with the Department of Human Services and the other agencies.
Well, do you want?
No, I'm going to have you
I know that
continue to chat. Yeah, because we did just get here Senator Tony Lourey, who's from District 11, and he is the chair of the Health and Human Services Finance Division. So we were just talking about how the houses want to kind of chat with one another and actually work together, which I know might sound like a whole new concept, but we're thrilled with that idea. So. Senator Sheran, why don't you continue chatting about some of your ideas and thoughts, and then we'll...
Well, I don't want to be repetitive. I wish I'd heard what Representative Liebling was saying, but, I think that, in particular, besides the obvious, the Affordable Care Act, which is going to be having elements of the law that we need to modify in order to come in alignment with the requirements of the Affordable Care Act, that will be fast and furious, and will take up a lot of the early time that we have in the legislature. And as a matter of fact, I was talking with Senator Lourey today at a schedule that lays out, at least for the exchange component, which Senator Lourey's been working on in a subgroup, so have you. is going to be moving along pretty fast through commerce and all the various elements of the various committees, eventually finding itself to health policy. But I'm looking forward to lots of other kinds of public policy discussions. We're going to start out, we're going to have some hearings on the Affordable Care Act to let people know what's in it, what the expectations are on our committees. And I wish we could align some of these things so that we're not duplicating. But if we can accomplish that even just in the Senate between Senator Lourey and I, that'll be a great thing. But also, the Reform 2020 is an initiative that I'm following very closely that takes a look at what I think is really a smart idea, to move the conversations earlier in people's lives about what are the options in the community, what are the gaps, what can we do to fill them, so that decisions about supportive services be made earlier in the process, so that a person isn't getting to some place where they're not able to manage their care, or because their age changes, they're on a completely different program, and they have to just go into some bundle or some place of service that may not be exactly correct. I really love what we're going to try to look at in terms of what I call menu organization around services that allows people to say, hey, this is what I need. I don't need the rest of that. And we can save ourselves a lot of frustration, and if we can get the systems in place where it's not complicated. What I always worry about is we have these ideas about simplicity and reducing complexity, and end up with something even more complex. Because we have this tension, I think, between, like in the PCA services, you have all followed this along, about overutilization, or somebody discovering a program like that and going into a private business and then exploiting it in some way that's outside of what the intent of the program is. And those few bad players out there create a whole new regulatory or anti-fraud initiative that makes the whole thing more complicated for the user to have access to it. And a lot more expense in terms of trying to have oversight or monitoring. So all our resources go off onto that, and away from being able to have a fair rate payment to people who are providing those services. But I'm really looking forward to our improving that for the consumer, for the person who needs the services, by targeting it correctly, having the customer help us target resources effectively, and other simplification processes that we can do to reduce the complexity of accessing services. We've been working on medical transportation, and as Sue knows, chaired the committee, and we will have something coming forward that sort of improves that. We hope to simplify it, make it fairer for both the consumers and for the providers of the service throughout the state. And even there, we're talking about finding a way of understanding that the issues in medical transportation are different in the rural part of the state than they are in the metropolitan part of the state. So one-size-fits-all approach to that problem may not be the right thing. And so we're going to have that conversation in this session. And that's something that we've been working on a long time. Senator Lourey and I have been very concerned about that for a long time. You've heard about the deficit, so somebody approached me yesterday about the big surplus that we have. Oh man, I gotta tell you, this is the language and the communication that goes on about that we've been left with a big surplus. These words confuse people, and it confuses the public to know that any excess revenue not spent in the last budget cycle goes to retire the K-12 shift. And there's still a big debt there. And then lots of money's coming out of our general fund for 20 years out because we have to retire the bonds we sold. And so we've already got a huge chunk of money that's committed out of every budget for the next 20 years, just $40 million a year, I think, just to cover a fraction of that in terms of what we actually use to balance the budget. That has put us in a very difficult situation. Another thing that I think will help this agenda in this community is the things that we can do, and maybe Senator Lourey will talk more about this too, to approach how we deal with sex offenders differently. Now, you might say, why am I bringing that up here? It's because anything that we can do in some of these that's a program where the people are going in and not coming out, and the cost of serving a sex offender under civil commitment in a hospital system, talk about the highest level of care, when it may be appropriate to have that stay in the correction system, where the costs are substantially lower. Anything we can do to fix that and move it through all of the political landmines that are in place around sex offenders relieves the Health and Human Services budget and makes these resources accessible for the kinds of, you're talking about rate cuts and serious problems and gaps that are occurring, the community service provider cut. How do we address those where we don't have enough revenue? It's by reforming and changing how much we're spending in other programs where that may not be the best and most appropriate expenditures. So I can blather on a long time, and I would prefer maybe to even take questions if that would be more helpful.
I think we'll do that right after Senator Lourey. We'll have time. So maybe we'll just jump right over here to Senator Lourey, things that you can add.
Sure. And, just talk a little bit. I didn't prepare a lot of talking points, but I'm equipped to talk about the needs of the disability community well. And just want to take this first opportunity to thank Minnesota State Council on Disability for their decades of excellent work on
year
helping.
40. This is the big year.
73, right? Was when it was created.
73.
It's fantastic, and we've really made some tremendous strides. Minnesota outperforms the nation on ADA compliance issues and goes beyond the bare requirements, and it's through the active support of our really engaged disability community. And as chair of the Finance Committee, HHS Finance Committee in the Minnesota Senate, I want everybody to know that you will always have a voice in our committee so that we never lose sight of where we've been and how we've succeeded as a state in embracing the needs of the disability community in everything that we do. So just that right off the get-go. I wish I'd been here in time to hear what Representative Liebling said as well. But
the good news is this is on DVD, so
there you go. I'll hear it.
By the end of the week, we'll have us on our website, so you can listen to yourself
later,
and everyone else.
Darn, I was going to say, don't tell them it's a secret.
We are going to coordinate extensively. I think that we're going to spend a lot of time later today, Tina. I see you on my calendar. We're going to be in a lot of joint meetings, trying to get started somewhere in the same place. The House and the Senate are different bodies. We will likely, at the end of the day, on every proposal, have a little different approach through the conversations that we've fostered through each of our respective committees. And we will treat those like adults and get together at the end of the day and talk about how it is that we got where we got and work out any of the differences and come forward with bills that make a lot of sense for the people of Minnesota. And that's how the legislature ought to be run. The administration will be there through that conference committee process as well, giving us good technical support and making sure that we understand the ramifications. And I'm really looking forward to this opportunity to move Minnesota forward, particularly on health reform in general. The Affordable Care Act implementation is going to be very consuming of our time in this first year of the budget. So we do still have a deficit situation in the state, and I think that the legislative majorities and the administration are all understanding that we've been talking about a balanced approach for a long time. That we're not going to tax our way out of deficits. We're not going to cut our way out of deficits. Neither approach is really in the cards for what the people of Minnesota are looking for. So we're going to have some difficult decisions to make. One of the points that I make, though, frequently when talking about our state's budget with all groups is we really need to be careful and understand where we've been through the last nearly a decade of serious deficits. And the fact of the matter is HHS has done the lion's share of the budget balancing in our state for that entire period. In the last biennium, with the $5 or $6 billion deficit. It was 6. It went to 5 with the forecast improving a little bit. The fix that was enacted into law, I use the term fix loosely, but there was 1.8 billion of actual cuts in that package. 1 billion of the 1.8 was on the backs of HHS, and that's very, very difficult to accommodate. And I need everybody in the state of Minnesota to understand that HHS has been doing this hard work for a very long time, and we need to be thoughtful and responsible about a health care reform agenda that we move forward for the state of Minnesota that's going to help our small businesses, it's going to help our big businesses, it's going to help our health care community, it's going to help our people. And we can do this. Minnesota is in a position to implement health care reform better than anyone else in the country, honestly. With our history with Minnesota Care and our status and our healthcare community that's ready to step up to the plate and embrace the reforms, I think that we really can be a shining star in bringing healthcare reform about. But we won't be able to accomplish that if we're asked to take all of the budget cuts in the global balanced approach that we are all talking about. And so that's something that people really need to help us with early on in the cycle. If we have a budget target that just doesn't work, it comes unglued. All of the important work that we have in front of us. The Affordable Care Act. I'm going to author the health insurance exchange bill. We are on a very tight timeline with that. We have to be done with the nuts and bolts of the exchange in March. We don't have till the end of May. That needs to include the governance structure of the exchange. It needs to include the long-term financing. The feds pick up the financing for the first period, but then we need to say how we're going to finance it when the feds start weaning their support of it, and we need to address navigators and brokers. Those are the three major pieces that need to be accomplished by the end of March. And we have at least 7 committees to get through to get that done, plus a conference committee where we bring the administration in and hammer out the final details, and then pass it probably just before Easter break. And that's a hard deadline from the feds. We agreed to accomplish that in the blueprint that we sent on November 16th to the feds. And if you think about that real quick, I know I might wind up chewing up too much time here, but January 1, 2014, we're live. These policies are active. There's a federal requirement of a 3-month open enrollment period, which backs us up to October 1st, 2013, for the products to be done, built, priced, approved, ready to be sold. The industry needs 6 months to build those products, and that is a process that usually takes 2 years. So the industry is very nervous, and that 6 months, that's what brings us to the March 31st. That's why we committed to these tight timelines. So it's going to be really important conversations and a really in-depth dialogue. I'm going to say right off the bat, we're going to have a bill in the first week, this week that is, for the health insurance exchange. It's not set in stone. We have a lot of conversations that are ongoing conversations, and we're going to have those through the legislative process. Some of them will be tense. We're going to be there. We're going to work through these like adults in the committee process. It's going to be open. It's going to be transparent. We're going to really work hard to understand everybody's insight and bring them forward, run an open process, and really get the best we can by that March deadline. Now, I need to go one step beyond that and say one of my really high priorities is that what we come out with in March is going to be just the nuts and bolts of what an exchange looks like. That doesn't take into account Minnesota's 20-year history with Minnesota Care and our support for low-income working Minnesotans and our assistance that we have always provided to this vulnerable population. And a standard implementation of the Affordable Care Act, of the exchanges in the Affordable Care Act, without something to support this population would move us backwards 20 years in terms of our support for this group of individuals. And so the feds have on the table the basic health plan. And I am going to be, it's going to be a very high priority of mine to bring the basic health plan or something at least as good to life. And one of the issues is the feds put the basic health plan in the Affordable Care Act as an option for states, but they have not been forthcoming with the guidance that we would need to actually craft a set of policies and a budget around what it looks like if we were to implement it. And so then we kind of can't, if we don't have the real nuts and bolts. And that puts us in a really difficult position. And so we're all working hard to get on the same page what our ask from the feds are. There's only about, 6, 7 states that thought they were interested in a basic health plan type approach. And the feds were really reluctant to do one. And they've been coming up with alternative deals with these states and winnowing down that list. Minnesota today is still very interested in the guidance on what a basic health plan would look like. We need to do something for this population, or the implementation of the Affordable Care Act, of the exchanges under the Affordable Care Act, would move us backwards, and that is simply unacceptable in this wonderful state of ours. We're going to get through that, but we need the guidance from the feds on at least the general contours of what type of agreement we're going to get to in the end of the day. And the deadline I've been saying is we need to know it before the February forecast comes out, because while it won't be completely fleshed out in this bill that we pass in March, that 6-month period that the plans have to build the products that are going to be sold on the exchange, we need to know that the income levels that they're building them for. And that's what the basic health plan is what are we going to do for different income categories within the exchange. And so we need to get this fixed with the feds. There's nothing on the table right now that we can implement with federal approval that allows us, with any degree of certainty, to put anything on the books today. We need to change that and finish that conversation with CMS, and we need to do it quickly. And we need help on that, making sure that our federal colleagues understand that dynamic, and we get through that discussion soon enough to at least put the basic framework in place for the March 31st bill, so that the plans understand what it is they're trying to get created and approved. So, I've been talking a long time. The sex offender stuff, we're going to work on that a lot. It's that's another federal one. The courts have certified a class for a class action suit against the state challenging the constitutionality of our sex offender program, and it's a pretty weighty challenge that we're facing, and we need to take it seriously. And with that, I'll
Okay, great. You know what? I think this is a perfect time for us to go to our sites and to ask questions. So
I have one right here.
You have one right here. We'll start with our email questions. And for those of you, if you want to email that you're on the web right now, council.disability@state.mn.us. And those of you at the sites, get ready with your questions. And in St. Paul here, we'll go to you last. So.
All right. Kristen online asks, as Senator Sheran and Senator Lourey have noted, there will need to be some creative solutions implemented in order to find funding for necessary services within the disability community. That being said, aside from looking at alternatives for sex offender treatment, what other programs may be looked at for innovative change that would create cost savings that could be used for funding things such as increasing employment opportunities for people with disabilities?
Well, there's little that we can do to reform within a year, and create this budget savings that we're looking for. But a lot of the healthcare reforms that we're trying to implement, if we do them well, and I honestly believe Minnesota can, we can meet the triple aims of the feds, which is better individual experiences with the healthcare system, and better individual outcomes. That's the one aim. Better population-based outcomes. That's the second aim. And through doing that and making sure that the healthcare community is really building the interdisciplinary approach to providing healthcare with the patient at the center, of that team, we can meet the third aim, which is bending the cost curve on the care that we provide. The care that we provide right now is more expensive than it needs to be out in the healthcare sector as a whole. You know, we need to have a conversation about what percentage of that needs to be driven by the public expenditures and public policies and how those all interact, and we need to be tracking budgets broadly beyond HHS budget into other budgets of the state and in our private healthcare spend as well. And there really are phenomenal savings. We've seen a lot of them come out. Hennepin Health is a wonderful example of how healthcare has been integrated with social services and the rest of the services, getting to the core of what the individual needs. The Department of Human Services is taking RFPs on healthcare delivery system initiatives around the state. A lot of really promising work done on that. You know, our old total cost of care approaches, accountable care organization approaches. If we do this well, and I believe Minnesota can, we really can generate incredible cost savings and meet the transportation and the employment needs of people broadly.
Yeah, I would supplement, you know, when I mentioned earlier some of the suggestions under Reform 2020. And an example of that would be if you, through the initiative, through waivers, if we're able to use resources to allow purchase of equipment, for example, or to have the resources in the community that haven't been available to the disability community because it isn't allowed under the program, then if we can, that's a reform, for example, that we're pursuing, so that those resources that allow a person to stay in their own home and stay independent longer, or stay in the workplace because that they have access to the kinds of resources they need to stay in that, rather than having to go, in order to get the support, into buying down their assets or spending out their assets and putting themselves out of what could be less expensive, less restrictive home situations and into the high expense. That's a major reform that we anticipate if we're successful at implementing it well. And like Senator Lourey, I think Minnesota can implement things well. You give us a lot of guidance as an organization. We listen to how to accomplish these things. These ideas have come from this community, you know, these cost savings ideas. And so it's really our job now to try to write legislation and get those things implemented. If we get permission, we get the waivers in place that allow us to have that kind of creative way of providing the supportive services that help people stay out of the situation that reduces the person's engagement in the community, engagement in work. We did one that we got going last. Took us 6 years, I think. Took us 6 years to get it done or longer, you know, for persons who are employed with disabilities to be able to stay employed and to not pay the horrific consequences you have to when you just simply because you turn 65 years old. It's those kinds of reforms that, along with the Affordable Care Act, along with healthcare homes, all things that help us pull in our resources and target them more effectively so that we can redirect them towards programs that support employment opportunities. And that's another thought for Christy. Was it Christy?
Kristen.
Kristen. Yeah. Kristen.
Okay, well, I think we should go to our sites. We've got a few of them out here. Let's go to Mankato. You can unmute your phone or your microphone, and if you've got questions or comments, now's your chance to either address Ann Henry from the Disability Law Center or our legislators. None. Okay, that's okay. Okay, next is, and then make sure to remute your microphone. Clay County. Questions or comments? Can't tell if there's anybody in the room.
No questions up here.
Great, thanks. And so let's look at, I think our other site, there was nobody there. So in St. Paul, if there are questions, we ask that you come up to the table where they're little, now they've got little spaceship-looking devices here, but they're black and they're in the silver, we asked you to come up front if you have a question. We can have you ask the legislators or Ann a question right now if you've got some. It's also thorough. There's no questions. That's okay. Dave, okay, Chris. Actually, you're right in front of it. I think you'll be fine, Chris.
Oh,
yeah,
okay.
Yeah, you're in front of it.
So, in terms of allowing people with disabilities to work and enabling people with disabilities as well as seniors to keep working, I wonder if there would be any consideration given to some kind of, I would call it flexible work law that would absolutely encourage or require larger employers to be more flexible in terms of the hours people work, or in terms of switching jobs, maybe to a job that's less physically demanding for someone who can no longer do the job they've been doing, as a means of accommodating people's needs. I mean, part of it is the aging of the baby boom generation and our parents, and we're having to take off time to assist our parents or get our parents' services, etc. And a 9-to-5 work schedule or 8-to-4 work schedule that's rigid like that really creates problems for both employers and employees. So I'd be interested in your thoughts on that.
Okay.
Well, I think, if I understood your question correctly, it's about a requirement or a regulatory process that requires or regulates flexibility.
Or it could be encouraged.
Encourage.
Lots of different ways.
That's, I was reminded today by Senator Lourey that this organization gave an employer in North Mankato a recognition, an award. And I want to read how this is described. So those of you who might be listening from Mankato, North Mankato, the recycling project in North Mankato, LGP Enterprises, was given a recognition as an exemplary employer for providing accommodations for applicants during the job application process in the work environment, disability awareness training for employees, job restructuring in order to accommodate to persons with disabilities, language interpreters, modified training materials. It's that kind of thing, that we would like to see encouraged, supported in the workplace. And a few years ago, we did an experiment with an internship program in the legislature in which we had a specific program for internships for persons with disabilities. I'm not always sure it's great to sort of slot the disability community out and have a special program just for persons with disabilities, but the goal at that time was to focus on what is it that we do in government itself. I mean, we employ a lot of people, the state of Minnesota. And what are we doing within our own system here to model and to be role models for what we ought to be doing to make the workplace more friendly, accommodating to a group of people who have enormous capacity to help achieve the goals and the mission of the state of Minnesota. If we get over our attitudes about that, or our assumptions, or our biases, or our prejudices, or if the physical plant or the physical situation that the person is in has some modification in order to it, we did this internship program as a part of, and that focused specifically on disabilities, the full range of disabilities, in order to try to bust out of this attitude or misinformation about dismissing or setting aside people with disabilities. And just assuming right out of the chute that they're not able to be a part of the workforce. So yes, those kinds of initiatives of encouragement I think are important. But I would call upon us as a state, as a major employer, to look in our departments and have our commissioners. Maybe we can ask them this question when they come up for confirmation, to say, what kinds of commitments will you make to the disability community being a part of your working staff? What are you doing to bring this into your state agency? Wouldn't that be great if we asked every new commissioner during their process in which they get confirmation to address that issue. I just think that'd be great. So,
Fabulous idea.
Maybe I'll talk to and just talk a little bit about the role of the legislature and public policy and how it moves initiatives in the state, and just say, a mandate to be more flexible can often result in a situation that doesn't have the broad buy-in and winds up more rigid than what we have today. I believe that businesses could benefit substantially from coming up with flexible ways to incorporate our baby boomers, like you mentioned, Chris. And so, I think that one of the roles of the legislature is to foster these really good discussions. So would I entertain a bill that had, a requirement or an encouragement? Yeah, we could. We could talk about it. We could bring people forward. It is a real way to have structured conversations around these important initiatives. And maybe we'd find ways to frame it and help the business community understand the benefits and take on many of these initiatives themselves without having to put it in the statute books. Oftentimes people come to us with these requirements that make a good deal of sense, but truthfully the statute book isn't necessarily the very best place to put a one-size-fits-all approach for how to achieve the goals that we're pursuing. So I embrace the goals, and I embrace the utilization of the legislature and our public policy making bodies to further those goals, and I'm open to whatever we can get in terms of broad buy-in to make them come about. And at the end of the day, it might just be that the conversation helps move the ball rather than actually getting something in our statute books.
just the question has stimulated I'm already thinking about what can we do, and this conversation. Another idea. I get crazy sometimes, but you've got to bust out a little bit before you retreat. We do a lot of grants. We do a lot of bonding bills. We do a lot of accommodations in the employment and economic opportunity area. It's not Health and Human Services, but it's coming out of Commerce. Why aren't we saying in the requirements section, not just, that there's prevailing wage, but that they're doing on-the-job training of people how to accommodate to disability, that part of the employer base be out of the disability community. A certain percent of the grants have, I don't know. Instead of thinking just in Health and Human Services, why aren't we going over, isn't this organization going over to those places where there are resources being given to companies, and then say, as a part of this deal, we have a really strong interest in asking you to incorporate persons in the employment or in the workforce that struggle with some form of disability. So it's just thanks for the question.
Great idea.
Joan, this is Steve at Nicollet County.
Oh, great. Sure, go ahead. Hi, Nicollet County.
I wanted to first of all thank Senator Sheran for the work that she's done in both Nicollet and Blue Earth County. I think that we're extremely blessed to have her as our area senator, and I'm really disappointed that Representative Morrow is leaving. He's been a real strong advocate for this community also. But Senator Sheran, you were talking before about the funding for the Minnesota Sex Offender Program. I worked for the Department of Human Services for over 20 years, both as a business manager for the Wilmer Regional Treatment Center and then at the St. Peter Security Hospital until I retired in 2008. And there is an inordinate amount of money that is spent on the sex offender program. And what is the process in changing the statutory laws relative to the Commitment Act and having sex offenders then stay in the correctional system rather than being posed into the Department of Human Services under a false pretense that they can be their problems can be adjudicated. I mean, why not just keep them in the correctional facility?
I'll just start, and then I'm going to defer to Senator Lourey, if you don't mind. Who was speaking? Stephen, if you don't mind, I'm gonna refer you over here. You've got a great resource here because Senator Lourey served on the committee that has been examining this under Chief Justice Eric Hankinson. But the essence of your question is, how do we make the changes? How do we get the support to make the changes that many people know? That the cost of dealing, the St. Peter Hospital that treats sex offenders, and why would we be talking about this at a disabilities group? It's because we're trying to figure out ways, as we discussed earlier, to extract resources from one area where we're spending money so it's available to support these programs. And so that's why this comes up here. But to the essence of the question of how, isn't this better over in the correction system? We have to remember historically that the struggle was, how do you deal with this chronic, high-risk population, high likely real offender population? And the solution that we came up with was a civil process, but it had to put people into a treatment modality. And the treatment modality is in a hospital setting, not in a prison setting, in a regulatory process that you have to follow, and the cost of it in a hospital as opposed to a correctional facility are substantially different, just the qualifications of the people that have to be there providing the services. So we have an interest in saying we are happy to use that kind of level of treatment where it's appropriate. But, and I think Senator Lourey can talk more about the conversations that are going on, do we need to change civil commitment law? Do we need to extend or lengthen the stays of persons in the correctional system rather than and provide treatment programs within the correctional system? Do we need to, on the front end, instead of committing everybody, recognize the differentials between the levels of sexual offenses and locate people in less restrictive treatment settings with very strong and powerful protections for the public? And then how do we help the public become familiar with that and understand the legitimacy of that approach, that it's based on public safety as well as on the pressure that's coming from the judiciary to change how we're using the civil commitment law. But this is not an easy task. You know that this has been a conversation for a long time, and it really, I think, needs leadership from the legislature, voices who are willing to talk very, very openly with the public. And you just know the people avoid it because in campaigns they go soft on sex offenders, and you're out of there in 2 seconds. But you need to get some legislators with some moxie to be willing to go out and say, we can talk about safety, and we can have high levels of safety in a known population, much higher than the safety is for the public in the unknown population that's living next door or down the block or sitting in the parks somewhere, We can't protect the public from the unknown, but from the known persons who are in the system somehow. That we have a great deal of resources that can decrease the risk, increase the public safety, without going into this hugely expensive hospitalization system.
Great.
So I'm going to turn that over.
It looks like we've got one last online question. And then we're going to have to wrap up the questions for this segment. So what's that last online question?
All right, so it says from Sherry, think about having multiple ways for people to access the healthcare exchange for people with a variety of needs as you build it. Maybe have some of the navigators or assisters can come from the disability community. The training of the staff of the healthcare exchange who interact with many Minnesotans looking for health care coverage could cover the typical problems and needs in people of disability and those living in poverty. It's a requirement you could make. It's just a suggestion.
Okay. That's not a bad idea. Well, and final remarks real quick from the legislators, and then we'll have to move on to the Olmsted report here.
Let me respond to that comment a little bit and say that it is very astute, and it was a large piece of the conversation that we had over in the Health Insurance Exchange Task Force that crafted some recommendations and a broad understanding that we need to reach out to every community in where they live and how they've accessed health care traditionally and improve the ability to keep those portals open and get the in-person assisters and the navigators working for the benefit of everybody trying to gain access to coverage through the exchange. And so that will be a core piece of the conversation that we have, and I am confident that at the end of the day we will have a structure that embraces outreach components that make sure that we don't lose the disability community in our exchange.
Great.
I've
had plenty to say. I'd like to defer my time back to Senator Lourey in case he wants to say something about the sex. He was on this task force on the sex offenders, and I talked too long. I'm sorry.
Well, since I'm holding down the House side of things here for myself and Representative Huntley, I think it's really important for the exchange. I think that's a really the question is a great one. My view of the exchange is that this is something that's meant to serve consumers. And it's meant to, the Affordable Care Act, we have to all understand, is a grand compromise. It's not it doesn't satisfy anybody. It has parts of it that are going to be wonderful and parts of it that are going to maybe not work out so well. It's a grand experiment and a grand compromise. And so my view and my orientation toward it will be that whatever helps the consumer is the direction that we ought to go. And what I mean by that, what I'm saying sort of implicitly there, is it's not meant for the insurance companies. The insurance companies are in it. They're selling insurance on it. This is a way to keep private insurance in the game while putting controls around private insurance so that to be less of a barrier between people who need care and the care they need. And so whatever we can do, such as this idea, to help people actually access it is, I think, something that's definitely worth considering. So we want this to be as user-friendly as possible, and for some populations, user-friendly is going to mean having a person who is accessible to them and who is comfortable for them and who they trust and who is knowledgeable, who can actually help them use this thing and make it work. So I like the idea.
Great thoughts. Senator Lourey had to dash off. The phone was just starting to ring for him. So I want to thank all the legislators, and Henry, too, for your wonderful thoughts and ideas of how we're going to move forward here with this upcoming session. So please feel free to stay for as long as you can. We're going to move on forward to our next, our last half of our session here. We're going to move forward with Chris Bell, who was the co-chair of the Olmsted Planning Commission, and or past co-chair of the CCD as well, the Consortium for Citizens with Disabilities. So welcome, Chris, and why don't you talk briefly about what the Olmsted Commission did and so forth, and what we're going to be looking forward to this spring.
Sure, thanks, John. The Olmsted Planning Committee was the first part of a two-part mandate coming out of a settlement of a court case, which would ultimately require the state to establish an Olmsted plan, which is due by June 5, 2015. What the Olmsted Planning Committee did was to come up with both background information and recommendations for the plan, and the plan is to be developed by DHS. I don't want to discuss per se the Supreme Court Olmsted decision, but its ramifications are profound. It's the equivalent of the 1954 Supreme Court decision in Brown versus Board of Education, which prohibited racial segregation in our public schools. The Olmsted decision under the Americans with Disabilities Act prohibits, in effect, segregation in institution or otherwise of people with disabilities. So it's a mandate for community integration, and community integration is defined as having people with disabilities in various contexts, whether it's housing or work or education or services, having them be in a position to interact with persons who aren't disabled. And so when you think about what that means, it's very profound. And one of the things that we're hoping to come out of the Olmsted Planning Committee is a sub-cabinet Olmsted task force that would involve not just the Department of Human Services, but also other state agencies that have to grapple with Olmsted compliance, like the Department of Transportation, the Department of Education, DEED, the Department of Corrections. There are many Olmsted issues there. Because that was one of the problems we had in the Planning Committee. It was just DHS and people with disabilities and families of people with disabilities. And the Olmsted mandate and an Olmsted plan has to be a lot broader than the Department of Human Services and a lot broader than medical assistance. So, in general, the Olmsted Planning Committee made recommendations that were founded on the principle that people with disabilities are human beings like everybody else, and that we have a right to make decisions about our lives and where we want to live and what services we need, what services we don't need, and where we want to work, how we want to participate in our community, and that the important part of that is to give people real choice. Obviously, that's within, to the extent we're talking about government or public benefits, that's within financial limitations. But in order to have real choice, for example, people with disabilities need information. Right now, if you're receiving benefits under MA, for example, we have an allocation system that allocates money from DHS to the counties based on a budgetary forecast. But people with disabilities themselves don't know how much money they would have to spend for housing, or don't know how much money they would have to spend for services. And without that information, people with disabilities can't make decisions, because like all people, we have to make decisions based on the resources we have. And if we don't know that, then we have to, in a sense, rely on other people to make those decisions, and that's part of the problem. Another part of our recommendations is the process to help people with disabilities get the services that they need, the housing if they need, et cetera, et cetera. And part of that is to encourage and expand our peer support network. We have self-advocates in the DD community. We have certified peer support folks for folks with mental illness. And we also called for the establishment of peer integration specialists to serve other folks with disabilities, and to actually have the state employ these people to a sufficient number. I think we called for 1,000 or 1,500 to create enough support for other people with disabilities so that they can help to learn advocacy skills and advocate for their own specific needs. Then we had many recommendations in areas of housing and community-based services and employment, and I don't have time to go into all that. The other big context is, of course, that the Olmsted decision is enforceable in court, and at the federal level is enforced by the U.S. Department of Justice, the Civil Rights Division, the Disability Rights Section. And they have been very active in pursuing litigation around the country to try to implement Olmsted, both with regard to facilities that would be comparable to our Minnesota State Hospital, but also with regard to getting people out of nursing homes and having a requirement that the states establish community services that would help people be able to stay where they are living, where they would have crisis services if need be, or places to go in crisis, and funding so that a person doesn't have to lose, let's say, their apartment because they've had to go back into the hospital for medication adjustment. So they have a way to maintain their apartment, because once you lose where you live and you come out of a hospital, you're kind of thrown into the system because you don't have a place to live. So those are the kinds of issues we addressed, and I know my time is short, so I will stop.
That's great. Okay. Thanks, Chris, for the update. Chris, where can people go for more information? And if they want to be able to, I realize the comment period time is over with, but
right.
If they want to be able to
you can get the Olmsted Planning Committee's document, it's our recommendations, by going online and Googling it, and with regard to DHS. It's a very complicated URL, which I don't write down. But if you go to Google and you talk about Minnesota Olmsted Planning Committee recommendations, DHS, you'll get it.
Okay, great. Thanks for the update on Olmsted. Very important work group, and thanks for all your work on that, Chris.
My pleasure.
We're going to move forward with our next speaker, Jean Wood, Executive Director from the Minnesota Board on Aging. And as many of you know, disability and aging, we all mirror our issues, and someday the aging, will creep up with us, with or without a disability. So it's important that I think we hear from the aging community and find out what's happening with them and how we might be able to work together and tag team, because I think that's important for us to collaborate and partner. So welcome, Jean.
Thank you. And thank you, Joan, for asking us. And I know we've been able to come for a number of years, and we are very grateful for the invitation. I'm the Director of Aging and Adult Services for the Department of Human Services, but in that role I also serve as the Executive Director of the Minnesota Board on Aging, which is a 25-member governor-appointed board that concentrates on the implementation and the management of the Older Americans Act, which is the original home and community-based act for older individuals, passed in 1965. My chair is Don Samuelson. He sends greetings. He is unable to be here to participate, but understands the partnership. The board chose 3 priorities this year. They are 3 priorities that are consistent with their priorities in previous years, and in keeping with their role of improving services for older people and for all people who are aging. And so that pretty much takes care of just about everyone, if they're lucky enough. Their first priority, and I will provide you a copy when it comes in its final format for distribution. The first one is to work with Prepare Minnesota for Alzheimer's disease. And as you know, a number of years ago, the board appointed a Alzheimer's disease working group that came up with some recommendations. It has now gone on to become a statewide collaboration of really medical, academic, community-based services that meet to discuss the implementation of the recommendations of the working group, now called Act on Alzheimer's. The board is very supportive of the work that this group is doing. It has things moving in many, many different directions. The board is really concentrating on elements of it like advocating for an Alzheimer's healthcare home, which for us is the start on chronic disease management in healthcare homes. The average older individual has about 5 chronic diseases that they need to manage, and so for us this is an opening up to the future. The second priority is around protecting vulnerable adults, and they have worked and been a partner with the Vulnerable Adult Justice Project that is convened by Iris Freeman. Primarily through the Ombudsman's Office, the Ombudsman for Long-Term Care, we have worked on strengthening guardianship and increasing penalties for people who commit abuse to vulnerable adults. And so we will continue to work with the Justice Project in supporting those policy changes, but we also are concentrating right now in the area of financial abuse and financial exploitation, and trying to advocate for additional resources going to counties, not only to do the very complicated investigations that go along with financial exploitation, but also the services that need to be delivered by the county in the event that they find that there is financial exploitation. The third priority is around home and community-based services in general, mostly around options and information. We are advocating for the expansion and earlier use of long-term care options counseling. The board believes that the earlier that people and their families receive reliable information about services and how to plan for long-term care, means that individuals will make and their families will make better decisions about that care and make decisions to potentially support caregivers also. Which leads me to the caregiver support area, which is another area where the board has concentrated on, primarily on the informal friends and family support, providing services for them when they are caring for an older individual, and by the way, also individuals with disabilities. So those are the three areas, kind of writ large. Are there any specific questions that people might have?
I think, are you able to stay throughout the duration of?
I can stay
a good portion.
Probably about 20 minutes more.
Okay. Well, I think we'll open up just a little bit for questions again, just in case. So, thanks, Jean, for the good information. I think it's always good for us to hear about the aging community, because we do really mirror one another in many of our issues, so it's important. I do want to acknowledge Commissioner Kevin Lindsay is in the room. Excuse me. Commissioner, did you want to make any comments at all as we move forward and speak about upcoming legislative issues from your agency up in the Department of Human Rights? You're welcome to if you'd like. If not, I always want to make sure the commissioners have an opportunity, excuse me, to speak if they would like.
Joan, I really don't have any prepared comments, but I do appreciate the opportunity to come and listen in. I really appreciated Chris's overview as it relates to Homestead. And when I went wishing to speak on behalf of Commissioner Jessen, I know that we've had conversations, so I know that she is in communication with her senior staff as it relates to moving forward, doing some things on Homestead.
Great, great. Well, thanks again for coming, and look forward to working with you in the upcoming session here.
Joan,
Thank you.
Excuse me, Chris?
Do you want some water?
No, I'm good. I've got some water. Thanks. All this talking. Anyway, up next now are some organization updates on some of the upcoming legislative issues. Let's see. I think we're right now going to bring up Rebecca. Rebecca, why don't you come forward? Rebecca Cummington. She is the new executive director of the Minnesota Consortium for Citizens with Disabilities.
Thank you.
So welcome. This is exciting for everyone to get to meet you firsthand here and hear about CCD's legislative agenda.
Well, it's certainly exciting for me to be here as well. Thank you so much for the invitation. It's great to be surrounded and join in conversation with so many individuals who are dedicated in really making positive change in our health and human services area, especially for individuals with disabilities. I am really excited to be here, and that's kind of a funny thing for me to say, partly because you hear all of this talk about the doom and the gloom that's going on in our political system right now. And how in the world can anybody be excited to engage in democracy when that seems to be all that we're hearing about? And the reason I'm excited is because I've had the opportunity now to become a part of an organization, a policy organization, that really represents what makes our democracy so great. An organization that champions individual rights to decide how to reach their best potential, and to continue challenging what it means to be an engaged participant within their own communities. Now, of course, the reality is we're looking at a tough fiscal year. We've got the governor's budget recommendations coming out on January 22nd, and then we've got 3 months worth of legislative work that our senators and representatives will be doing in St. Paul to figure out how they want to shape their budget. And by May, hopefully those two things are going to come together, reconcile themselves, and allow for a budget that really does facilitate greater independence for individuals with disabilities. And what CCD is going to do, the Minnesota Consortium for Citizens with Disabilities, is engage in the unique partnership that's been going on within our organization for dozens of years in partnering providers, direct support service agencies and organizations, advocates, and communities in informing that budget process the absolute best way that we can to ensure and protect the rights of citizens with disabilities. Now, this comprehensive approach is a really great opportunity for us because we have the scope to address areas that impact citizens with disabilities, from education, housing, transportation, employment, engage a lot of stakeholders that need to be part of that conversation to make sure that their voice is heard at our state capitol. We have a couple of focal areas that we're going to be looking at within our legislative agenda for the upcoming 2013 session. One of those is Reform 2020. We are going to be looking very closely at Reform 2020 and following those items that we feel are going to best support community-first services and supports that focus on quality of services and self-directed services, and really work to realign a system that places the consumer in control of the decisions that they need to make sure that they are reaching the best potential that they can within their community. We are also going to be looking at the disability waiver rate system, state health care reforms as well, the creation of the health insurance exchange that Senator Lourey referenced and was quite gracious in giving us insight into how that process is going to go for them this legislative session, to really ensure that the essential benefit set is defined so that it includes those services that are having the greatest impact to citizens with disabilities and making sure that those are included in that health insurance exchange. We are also working on several specific items for CCD, one of which is a narrowed list of unallowable items in consumer-directed community supports. We are going to be working to shape our legislative agenda as the governor's budget draws closer and we get that February economic forecast for the state of Minnesota to figure out the best ways in which to plug our advocates and our direct service support advocates into that legislative process to make sure that their voice is heard with their elected officials. We know that policy changes lives. Every one of us in this room works in an arena where we see that every single day. We will be doing this legislative session a lot of work to make sure that our elected officials know that the decisions that they make also change the lives of citizens with disabilities, and making sure that our voice is a strong one at the state capitol this session. In that, we will be continuing our Tuesdays at the Capitol starting on January 22nd, and do invite many of you who work in the arena of health and human services to be advocates at the Capitol, to our elected officials who are charged with making these important decisions. That is it for me. We will be finalizing the draft and scope of our direct legislative targets soon, and be putting that up on our website for everybody to be able to access.
And what is that website for everyone?
That website is really easy to remember. It's MN-CCD.org. I look forward to any questions or comments. We'll have our contact information, our new contact information up on our website very soon.
Great. Well, welcome to the disability community, and thanks for your update. Well, since I'm getting croaky, I'm just going to keep passing things over to the other people here. To my right here is Sue Aberholm, Executive Director of NAMI, National Alliance for Mental Illness, and we welcome Sue to chat about your legislative agenda and as you've had some busy, kind of a busy year in many respects.
Yes, and I'm actually representing also the Mental Health Legislative Network, which is about 20-some organizations involved in both kids and adults' mental health issues. One of the issues clearly is sustainable mental health infrastructure funding. We want to make sure that the 2007 Mental Health Initiative, that those dollars continue. That would include grants for mental health crisis services, supportive housing, all of those kinds of things. Sustainable funding and payment rates and treatment funded by Minnesota healthcare programs. Ann mentioned them briefly, but children's therapeutic services and supports, intensive residential treatment services, adult rehab mental health services, day treatment. A lot of them are really, frankly, starved for funding. They can't hire staff, and we've had some day treatment programs actually close. The mental health community is concerned about access to some of the community-based services such as PCA and CADI. The needs of people with mental illness are very different than the needs of people with other types of disabilities, plus the fact that we have a whole lot of folks who don't even consider themselves disabled because they believe in recovery. And so we just want to make sure that when we're creating these one-size-fit-all programs that we actually make sure that we fit in the needs of people with mental illnesses. We are looking at quality mental health services in the era of healthcare reform. The exchange is a really important piece for the mental health community because for the very first time for individuals in small groups, mental health services are actually mandated, which is a whole new thing that will actually bring, we think, a lot of new money into the mental health system, along with they have to follow mental health parity. Because of, frankly, some of the recent tragedies across our country, several of us met on New Year's Eve, what a better way to spend the day, right? And created a children's mega mental health bill. And I'm just going to briefly go through some of those. Knowing that half of all adults who have a serious mental illness began experiencing symptoms before the age of 14, for us to continue to have an awful, unfunded, inaccessible children's mental health system that's even worse than the adult mental health system is just unconscionable. And so one thing we want to do is improve access. To do that, we'd expand the Schooling to Mental Health Services grant, which is really the best thing since sliced bread. We've served over 8,000 children in the last 4 years. Half of them have never received services before, and half of them have a serious emotional disturbance. No wonder they can't do well in school. We're only about in 17% of the schools, not school districts, but schools, and so we want to try to get up to like 25 or 30%. We want to expand the use of the Safe Schools Levy to hire more support personnel and to pay for necessary costs for folks who don't get a grant to actually bring mental health professionals in. We want to require, as part of the healthcare curriculum, health education, that we include mental health and mental illnesses for middle school and high schoolers so that they understand the signs and symptoms as well. Some kids don't know it's not normal to hear voices because that's what they've grown up with. We'd also like to make sure we fund child care for young parents who have a mental illness. This is a real barrier for them in obtaining treatment. We want to expand on our teacher education bill that we passed about 8 years ago to make sure that once you've gone through that first set of trainings for early warning signs of mental illness, you can actually go more in depth in things like trauma, focused care, and things like that. We'd also like to set aside some state dollars for the first time for positive behavior interventions and supports so that the current teams can continue as they need to hire and train new staff. We want to create a continuum by doing contract beds like we do in the adult side for children's inpatient care, creating the PRTS, which is the kind of in-between hospital and residential level of care, redesigning the CABS program so it actually meet the needs of kids. We'd like to expand the in-reach services we currently do for adults to children, both for inpatient residential and juvenile justice facilities, providing clinical care coordination, and then increasing the funding for children's mental health crisis teams, along with making sure that the teams, especially in greater Minnesota, that have just used adult mental health professionals, that they actually get training on children's mental illness so that they're working effectively with families. We have a huge workforce shortage issue, so we'd like to convene a summit with the Minnesota Higher Ed Commission and the Children's Mental Health Division to really come up with recommendations on how can we create some more career paths, how can we increase the number of culturally specific providers, and how can we ensure that the workforce can actually hit the ground running when they leave school. We'd like to provide mental health first aid training for people working with children and to look at developing a mental health consultative model using culturally specific mental health professionals. We'd like to support families who have children with mental illness by increasing the funding for respite care, creating a family peer specialist role, kind of similar to the peer specialist role that we use in the adult mental health system, but this time using parents, funding both family psychoeducation and family engagement under medical assistance. We'd like to separate out once and for all child protection and children's mental health. I would just, for any of you out there, can you imagine, being in greater Minnesota, trying to find treatment and services for your kids, the county not really responding at all, and now all of a sudden you end up in the CHIPS system because your child needs services that you were unable to get. Additionally, for families whose kids need residential treatment, they are threatened with CHIPS petitions over and over and over again. We also have families whose kids are in the emergency room or ready to be discharged from the hospital. They say they don't need hospital level care anymore, and there is nowhere else for them to go. And they say, I cannot bring my child home. I cannot keep them safe in my home, or perhaps younger children safe. And so what happens is they call the police, they do a health and safety hold, and a CHIPS petition is started. So we want to clarify that medical neglect doesn't include parents who are actively involved trying to get their kids treatment. It's just time for these two systems to just be done with each other. Lastly, we want to make some change to some of the current programs to improve their effectiveness by adding when providers have to do the CASI tool outcome measure, that gets reimbursed. We want to make sure that therapeutic foster homes continue to be paid for, which is a new service. We want to create a certification process for behavioral health aides number 2 by actually creating kind of like community health workers, that there be a college system in our community college that then they could do that and they would get paid more. And this again would be a career path. We'd like to fund training for community health workers on mental illness in kids and adults. And then lastly, we would like to make sure that, sorry for health plans in the room, but there is research-based protocols for medication for first episodes. So young people are having the first psychotic episodes. They should be able to have access to that medication that research has proven has worked well with first psychotic episodes and not have to go through step therapy and not have to fail first before they move forward. We want the trajectory of those kids' lives to continue in the direction that's supposed to go in. And that's it. And unfortunately, I have another meeting to go to, so I can't stay proceed. But we're very excited to try to move some of these things forward this year.
Well, thanks so much for letting us know about all these initiatives. I think the majority of us probably aren't familiar with some of those issues. So thanks so much.
Thank you.
Next up, we have Steve Larson. Steve is the Senior Public Policy Director of ARC Minnesota. So welcome.
Good morning, Joan, and everyone that's both here live and on the video conference. I'm going to touch on several things that have already been mentioned, but maybe go a little bit more in depth. One of the key dates coming up is the governor's budget, which will be released on January 22nd. And in the governor's budget, we'll hopefully have some relief from some of the things that happened in the past and be able to move forward in implementing some of the legislation that passed in 2011 and 2012. One of the things we'll be anxiously watching for in the governor's budget is how he addresses the 20% relative PCA issue. For those of you that aren't aware of it, the appeals court had ruled that this was not acceptable, and so hopefully the governor will move forward and fund this and correct it in his 2014 and 15 budget, and we'll be done with this particular issue. We will still have to watch if it's in the governor's budget, make sure that it stays in the budget and that it's approved by the legislature, but our lobbying efforts will be much simpler if that's the case. If that's not the case, then this is something that we will work on resolving during the 2013 legislative session. During the 2011 legislative session, the authorizing legislation passed for Reform 2020, and we're very anxious to see Reform 2020 move forward. And some of the key elements in it that we'll be monitoring are the transformation from PCA services to community first services and supports. This is a major step that we've been working on for several years. It's important that we monitor what's going on. The Department of Human Services will come out not only with budget issues, but they'll also come out with language. Usually that language needs to be modified in some form, and so we will share with the disability community what that language is, get your input on any ways that we can improve it, and be testifying at the legislature on the transformation of PCA services to community first services and supports. This is a major endeavor, it's a major system change, and it's one that we all need to pay attention to. We're also looking for Reform 2020 to help lead the way in expanding self-direction. Currently about 30,000 Minnesotans are on consumer-directed community supports. We think that number should be tenfold, and that all Minnesotans should know how much money is allocated to them each year and how they can possibly control that money or change their lives to benefit from that. And so again, we're going to be working with the Department of Human Services, with the legislature, to see if we can get transparency, more transparency in that particular area. Also included in Reform 2020 is a work group working on individuals' potential legislation for individuals with autism. We all know the statistics that it's now 1 in 88 out of students that have an autism diagnosis. This is an overwhelming crisis that we're looking at here, and we need to make sure that we're set up in the community to address those particular needs. One thing we'll be working on is moving towards private insurance coverage for therapies, an issue that has been at the legislature for several years. We think this is a year that we should make progress in that. And why is that important? Because it's important that the therapies be early in the individual's lives, the child's lives, and that it's accessible. And by having private insurance not paying for this, many families are not getting the therapy for their child that they very much need. Also passed in 2011 was quality assurance legislation. And this is moving forward. A quality council has been meeting since March and will be coming up with recommendations that include creating quality assurance regions, several counties, and developing consumer-based reviews based on whether the individual with disabilities is achieving the outcomes that they want. And so we're excited about working on implementing that particular legislation. Chris had gave an overview of the Olmsted Planning Committee, and one of the items in there is to create a plan to reduce our waiting list, which we think is extremely important. And another recommendation is to create access to market rate housing that individuals control. Having housing that individuals control is vitally important, and the ARC of Minnesota has worked for 3 years now with their housing access services, and we've demonstrated that many individuals can live a more independent life if they get the services they need to move forward. And we'll also be looking at the moratorium and its impact on people's ability to move out of their family home or to access services when they're homeless or when they're in crisis, and see what comes of that as far as any potential legislation. Lastly, we'll be looking at lowering parental fees. 5,000 children in Minnesota now access medical assistance, and they have to pay a fee which is based on a sliding fee scale. We think thousands of more children are being denied necessary health care because they cannot afford the parental fees. And so we will be working to develop legislation to try to at least lower parental fees and bring this issue to the attention of our legislators. I look forward to seeing all of you at the Capitol, at Tuesdays at the Capitol, at the various days at the Capitol, and at hearings on bills impacting persons with disabilities.
Thanks, Steve. Well, next up, we have some individuals from Advocating Change Together, otherwise known as ACT. We've got Christy and Darren, and looks like we've got Haley as well that will talk about Remembering with Dignity. So I'll let you three talk about the issues that are important to ACT and so forth.
Great, thank you. We are not Rick, as you mentioned, but we are here just to talk about the focal areas for Advocating Change Together this year. So we're going to be talking about 4 different areas. The first is SAM, so Self-Advocacy Minnesota, Remembering with Dignity, like you mentioned, and then also Housing and Jobs. So my name is Christy. I'm interning with ACT this year, but Darren, you can start off with
Hi, I'm Darren. I'm new to SAM, Self-Advocacy Minnesota. This is my first year of joining on board with them. We are willing, well, we are not funded, really are the only 6 funded regions that are not funded because we are the metro area, and we would like to get funded because all the other ones are funded but not us. So we were just wondering if we can get funded for that so we can continue on doing what we've been doing. So, and basically just continue on what we've been doing for SAM. We would like to do a new program, put in the SAM, and then jobs up before Christine goes into the jobs. I would like to add into it before she goes into it. For us, people for like day programs, it's kind of hard for us to find an outside job because we're on a day program, and we would like more people to help out with that so we can actually get an outside job and not at a day program, but it's hard for us to find that opportunity to work for an outside job.
Right. So as Darren had mentioned, there are 7 regions that are funded by SAM, or excuse me, there are 7 regions that SAM consists of, but the metro is not funded, and that was decided because the leadership circle wanted to fund as many resources as possible to the rural areas that had fewer options available. But SAM is hoping to expand and maintain their current network in this coming year, including within the metro. And because Darren mentioned it, the jobs, I'll mention that as well. Like he said, there are a lot of hurdles for people, particularly who are involved with day programs in accessing jobs. I think everyone here knows that. But there was a SAM meeting on December 7th, and the members of SAM decided and noted that jobs are actually the number one obstacle they face in living the lives that they both want and deserve to maintain. And ACT and SAM are trying to address that by really focusing on the people with disabilities themselves rather than job coaches. So they're expanding a program of peer-led trainings to focus on ensuring that people with disabilities really understand the basic steps involved in finding a job, in job readiness and job-seeking skills, as well as how to access necessary supports and services needed to find that employment, and to focus on skill building as well. And then Shante was going to talk a little bit about housing and her experience with that.
Hi, I'm Shante Marin. One of my goals is to move into a subsidizing home one of these days.
So, like Shante said, another primary goal for people with disabilities is moving into independent housing. And again, SAM is really focusing on increasing the support for people with intellectual disabilities and developmental disabilities who are both living in the community with supports as well as people living in restrictive settings. And that is, again, going to be focusing on peer-led programs that really focus on increasing the success of community of folks that are living in the community by informing them of their legal rights, informing them of how to access peer supports for making decisions, problem solving, for exploring options, and then also, again, implementing skill-building curriculum that focuses on education, on employment, and transportation and voting. And again, those funds would be distributed out to the 7 self-advocacy regions covered by SAM. And then finally, the program that I'm most involved with, and Hallie is here as our community organizer with Remembering with Dignity. So if you have questions, please talk to Hallie. But Remembering with Dignity is a project to replace the numbered graves for the thousands of state hospital residents that were buried in state cemeteries with proper gravestones, with names, with dates. The state has made a commitment to complete this project, which we're very thankful for. And so far, already 7,817 of those graves have been replaced, but there were 14,000 total. So there's still a lot of work to do. We're working specifically on Faribault and St. Peter right now, and it's incredibly time-consuming. It involves a lot of verification. The records are generally messy and inconsistent. In a lot of places, they've actually been lost. And so we're hoping to continue that and kind of fill in some of that gap. Last year, we were promised some funds, but that didn't come through. So we are hoping to get some of those to continue that work today, this year.
Yeah, great. Thanks so much for that. It's a good update. As you can probably tell from our agenda, we've got some cancellations and then some other people filling in, which is great. So next up, we will have Michelle Gray from Minnesota Brain Injury Alliance. Welcome, Michelle.
Thank you. Thank you, everyone. Good to see you. And thank you for the last-minute addition to the agenda. I'm happy to be here to talk about our public policy priorities with the Minnesota Brain Injury Alliance. As Joan said, my name is Michelle Gray. I work in public policy for the Minnesota Brain Injury Alliance. We are a statewide nonprofit organization that provides outreach, public policy advocacy, resource referral, and case management services to individuals with brain injury, their loved ones, and the professionals who work with them. There are currently over 100,000 Minnesotans who have lived with disability as a result of brain injury. So I'm here today to talk about some of our public policy priorities that will guide our work over the next 2 years. So first and foremost, as many of my colleagues have mentioned, is monitoring and watching the conversations with the Minnesota state budget, considering it's a fiscal year and forecasts are projecting another deficit for the upcoming session. It's really critical that we work to protect the funding for brain injury supports and programs and services in the health, human service, education, special education, and other areas of the state budget. As I mentioned, our colleagues have gone into greater detail about some of those specifics, and we will work with them at the Capitol on the critical health and human service issues and looking at the Reform 2020 in some of those areas. So we look forward to working with them on that. Also really important to the Minnesota Brain Injury Alliance is prevention of brain injury. So this is a kind of a unique conversation I can bring to the table is a prevention of brain injury. It's very important. Not only does it reduce the physical, emotional, and financial toll on individuals and families, it also reduces the economic impact on our health and human service budget. So our main priority in the area of prevention for the Minnesota Brain Injury Alliance is to reduce the severity and the costs of traumatic brain injury as a result of motorcycle crashes. And we want to do this through increased insurance coverage, the personal injury protection part of insurance coverage, and also increased helmet use. So we will continue our efforts to pass the motorcycle helmet insurance bill. So if you are interested in looking at prevention of brain injury in any of that area, we look forward for you to get into contact with us. A couple other areas on our public policy priority agenda are protection of the traumatic brain injury and spinal cord injury fund at the Department of Health. This funds the brain injury registry for the state of Minnesota and also the critical resource and outreach services through our resource facilitation department. And also with our merge with the Minnesota Stroke Association within the last couple of years, it's very critical that we are working with them to find ways to promote stroke systems of care and stroke prevention. So I'll keep it brief since I was a last-minute addition, but I do have the luxury of our legislative priorities there's a link on your agenda in case you want more details, or feel free to get into touch with us. So I look forward to working with everybody on these issues and our prevention agenda, but also we work really hard to get our advocates with brain injury engaged in the discussions. Sharing their personal story with brain injury really helps us be impactful at the Capitol on these issues. So,
thanks, Michelle, for jumping in on too in the last moment. We appreciate it because it's good information to be aware of.
Thank you very much.
And now, next up, we've got Efficient Knights from Consortium. So welcome.
Hi, thanks, Joan. Thanks to Joan and the State Council on Disabilities for this forum. It's been really great learning different things about some of the different organisations. I'm going to try and do this and not include stuff that's already been gone, although I kind of feel like the kid who didn't put his hand up earlier in the class and he's got all the good answers out. So I'll dig down a little bit deeper into some of the weeds.
We'll still listen.
Yeah, the Consortium has been going through some different things. On my side, we're going to be partnering with Alliance Health. So some of the work we're going to do is going to do more in the healthcare world. The things that we are looking at this session, I think a lot of them are going to get to the heart ads, the fact that we have a deficit, the fact that we still really haven't fixed these structural issues. That means every year, as I think Anne mentioned, we really do face these threats of cuts. So let's look at ways in which we can prevent them, find some innovation so we can make cost savings, and maybe prevent the disability services from facing cuts in the future. The first one is to accelerate demonstration projects for those people with disabilities and complex health conditions. DHS has been doing some great work on new care delivery and payment model systems, things like asthma, things for diabetes. Unfortunately, people with disabilities, programs like that have been largely excluded as of right now. It's not been kind of a priority, and so we would really like to open that net a little bit wider and give opportunities for cost saving and integration for people with disabilities. It's often said it's kind of the most expensive. It's the top 5% of the healthcare costs. So if we can start hitting at that cost, I think we're going to be some way to making some cost savings. The second one is measures of success are desperately needed. We really need to be able to define what programs are successful, what programs are failures, particularly on Medicaid waiver services. Without that, I think we're going to continue to see our services, threatened in the budget because we're not able to say if they're working or they're not working. So, trying to find those. The quality indicators do exist for the general population right now, but I think we need to do a lot more work on that for the disability community. One that's, I think, very important, talking about how much community services people have talked about here, and viable payments for hourly, low-cost, community-based services. We have a really strong ILS program that we started, and it was in response to providing people those services, independent living, so they can stay in the community and not in institutional care. And DHS has been working a couple of years on the new payment methodology for this, and as it was kind of originally came out, it would see our program, our ILS program, which is the largest ILS program in the state, cut to the tune of about 30 or 40%. And if any of you know anything about Courage Center, we lead on loss leaders. Most of our programs don't make a lot of money. In fact, most of them lose a lot of money, and we certainly don't operate on a 30% margin. So it would really threaten the viability of our ILS program. And these are services that are critical to maintain independence and health of people with disabilities. So we're hopeful that that'll be something that we can come to a good agreement on. And then just finally, kind of on that theme, comprehensive MA reform. I think we still need to go through that. The Affordable Care Act has got a lot of interesting and good, fun developments in there that I think we can follow through. For Courage Center, I think the two big ones: payment reform. We lose $800 on average for every client with MA who walks through our doors. It's not a real model that's going to be useful, but we feel like we save money in a lot of other areas. So we would really like it that if we could start doing something where we're rewarding providers for saving money, for cost savings. And then the other one is the expanding care coordination. We have a healthcare home that I heard, I think Senator Lourey had mentioned earlier. It's a very successful healthcare home. We have over 200 participants in it. These are people who, on average, have 11 secondary conditions, and we've managed to reduce their hospitalization days from 12 days on average per year to 2 days on average per year. It's a cost saving of about $2.3 million over every year. We don't see any of that money, though, and we lose a lot of money on the program. And, we're continuing to do it because we think it's the right thing to do, and we think more people in healthcare home would really help coordinate their care. But there's going to be a point in which, that payment side has to come through to really reward it. So there's just a few other things. And then just the one last thing. January 18th, MN-CCD has its healthcare kickoff, where we're going to have leaders from the House and Senate on the Health and Human Service side, and also some experts from the department. There will be free food and hors d'oeuvres provided. It's at the Kelly Inn, and I believe it is from noon until 1:30. So, and it'll also give you an opportunity to maybe meet Rebecca a little bit more, because she's going to be hosting and moderating the panel for us. So, RSVP to me. If you go to the website, MNCCD.org, if you go on the events section, it tells you how to get everything. It's a free event, and we invite everyone and anyone.
Mm-hmm. We'll try to link to that as well, so
Great.
whether they come to our site or with CCDs,
perfect.
there'll be a way to get it, because that's fabulous. So thanks for the great update on everything. So. Well, this actually concludes our presentations by disability organizations, unless there's anyone else in the room that wants to we've had a lot of sneak people that just snuck in on some of the things which are good, but I think we'll go out to the locations, see if anybody has comments or questions. And why don't we go to Mankato? Let's see if anyone's still in Mankato, if you've got thoughts or questions. You can.
No comes thanks.
Great. Well, thanks for participating today. What about Clay County?
No comments or questions here.
Okay. Then Nicollet County is the other one.
Hey, Joan. The one comment that I wanted to make to the area legislators before they left is that, we hear a lot of discussion about, employing people with disabilities I think there's a lot of people that are highly qualified and skilled to be in the workforce, but I think really what people need that have a disability is a break. That's all people really need is a break, and from there they can prove that they have the skills that are necessary to do the jobs that's required.
Okay, good point. And we just need a break so we can improve ourselves. So thanks for that comment. And St. Paul, we've got folks here. Some are coming and going here. So any comments, questions at all? Maybe if you howl loud. And we've gotten these new fancy dancy little domes up here that are really picking up everything. Crunching of our paper, the whispering. And so anyway, so you're welcome to make a comment quick or thoughts. Anyone? Dave Hancock's from the Metropolitan Center for Independent Living.
Thank you.
Hardly miss an opportunity. Got it.
Thank you, though.
That's right.
Thanks for calling me out.
Yeah. Anyway, well, great. Well, certainly we don't mind getting done early, and so I want to thank everybody for participating. What about online? Did we have any online comments? Appreciate those folks participating online, everybody who came into the locations. And so definitely be active at the legislature in every way that you can. And we look forward to seeing you at our next event. Thanks, everybody, for participating.
Thank you.
Thank you, Joan. This is Steve.